Hi, everybody. My name is Sahil Parikh from Columbia University, New York, and I'm excited to have you here for another JSCAI Conversations in Interventional Cardiology. I'm one of the associate editors and associate professor of medicine at Columbia University, New York, and I'm honored to represent the JSCAI editorial board, especially our editor-in-chief, Dr. Alexandra Lansky. We're just delighted today to have a great multidisciplinary panel to talk about a paper in JSCAI entitled Safety and Feasibility of the RevCore Catheter for Venous In-Stent Thrombosis. And I'm really delighted to have a couple of the authors of the paper and another thought leader in the field with me. Dr. Abdullah Shaikh is an assistant professor at Drexel University School of Medicine and an interventional radiologist at Allegheny. Steve Abramowitz is a friend and colleague from vascular surgery, the chair of Department of Vascular Surgery at MedStar Washington Hospital Center, and assistant professor of surgery at Georgetown. And Hillary Johnston-Cox is an assistant professor at the Zucker School of Medicine in Hofstra and Northwell Health in Long Island, New York. Thanks to all of you for joining us. And Dr. Shaikh, why don't you start by sharing your paper with us, and then we'll have a discussion.
Yeah, thank you, Dr. Parikh, for that introduction. So yes, this paper is entitled Safety and Feasibility of the RevCore Catheter for Venous In-Stent Thrombosis. This is a multicenter retrospective study done over 4 centers, and these are my co-authors as well. So just some background. Anyone who does venous work knows that once you lay a stent, you're inevitably going to have some issues in the future. The data that we have right now looks at all these different stent companies that have produced stents. It's out to about 3 years. And the gist of it is that if it's post-thrombotic in nature, it's going to be about 70% patency. If it's not post-thrombotic, it's going to be about 90%. So we really don't know what percentage of that stent really has to go down before patients are starting to experience symptoms. And so we want to get ahead of it if we can. Additionally, if the patient does have symptoms and the stent does go down, we really don't have great tools out there that'll allow us to really clean that stent out. We've always been able to just piecemeal it and then try the best to salvage it. But in the end, a lot of people just end up relining these stents or extending these stents, and just more metal creates more issues in the future, especially in the younger ones. So these are challenging to treat, and the modalities available are very limited. And the RevCore mechanical thrombectomy catheter is a new tool that's been designed specifically to address this issue. So the aim of this retrospective study was to really look and see the safety and feasibility of this unique thrombectomy catheter. The design of this was that we looked at all patients from March 23 to November 23. We included anyone over the age of 18 who had an iliofemoral in-stent thrombosis. These patients were treated using the RevCore thrombectomy catheter over 4 centers. Our primary endpoint here was really post-procedural effective diameter of greater than 50%. All right, so that's looking at really taking the ratio of the patent lumen and the actual stent size and getting an effective diameter. And then secondary endpoints of a 30-day device-related major adverse events such as mortality, readmission, perforation, and clinically significant PE, mostly defined as massive. So the study population essentially was 44 patients that were treated using the study device. So with those 44 patients, we technically had 48 limbs and 65 stents. Baseline characteristics overall, the majority of the patients were in their 50s, they were female, and these patients had at least 8 weeks duration of symptoms. 7 of these patients had C6 disease, so with ulcers, and we had a very low average effective diameter at 21%, and the actual area within these stents, the flow channel area, 16 millimeters squared. Procedurally, we reported more than 90% of this thrombus was removed. The thrombectomy time, this was early on, and I'm sure this has improved since then, but it was close to 30 minutes. We had about chronic thrombus extracted in the majority of these patients. And the effective diameter greater than 50% was in all patients as an endpoint. But what we found, the average effective diameter to truly be in these patients was 90% when we were completed. The average flow channel area also increased almost to 130 millimeters squared. And then no stent migration or entanglement with the study device. When you look at patency at the baseline, the majority of these stents were occluded. Some of these stents were partially occluded. And then post-procedurally, we had almost 94% of these patients had complete or near complete patency, with about 6% showing partial. So we were successful in opening up all of these stents. And then the flow area, statistically significant findings going from 16 up to about 133, almost an 8-fold increase from baseline. With regards to safety outcomes, everyone wants to know, like, did you cause PEs? Did you break the stent at all? Did you have any mortality-related issues? And we're pleased to report that nothing occurred from time to follow-up in the first 30 days and then up to the 40-day first follow-up period. So here's a Kaplan-Meier curve which showing patency loss events through the first follow-up visit at all such events occurred prior to the median time to follow-up of 40 days. There were 2 limbs that lost patency prior to the median time for follow-up. One was due to rethrombosis from non-compliance with anticoagulation and a new malignancy diagnosis, and the other just required a repeat procedure of using the study device. When you look at the patients that had wounds, we had 5 of these patients, and we had some area measurements available. So almost 10 centimeters squared at baseline, and at the 3-month follow-up, the area after cleaning out the stent, relieving the venous hypertension or improving the venous hypertension, led to a significant decrease in that wound area at the 3-month follow-up. From this, we were able to come together and design the RevIT study, which is now going to be looking at 100 patients across 30 U.S. sites, looking at successful stent recanalization as our primary endpoint. And then we've got secondary endpoints looking at device-related adverse events, imaging follow-up at 30, 60, and 1-year marks, and clinical outcomes at the same time points, looking at SEEP scores, Volta scores, and quality of life. So in conclusion, this RevCore catheter we've shown it to be successfully used in the treatment of in-stent stenosis and reestablished stent patency. We've had no device-related SAEs, demonstrating a favorable safety profile, and hopefully with the RevIT study announced, that'll provide further evidence, give us a follow-up imaging protocol and what's going on long-term with these patients as well. So that's what we did with the paper, and happy to discuss where this is going, where this field's going to take us.
Great. Well, thank you so much. That's, I think, incredibly interesting for people in the field. I think many interventional cardiologists are not familiar with the complexities of large venous stent-related failure. But those of us that do this for a living recognize that these are some of the most vexing cases often, starting with crossing the occluded stent to then dealing with the residual sort of almost cement-like material that's inside of those occluded stents. All of us recognize that those cases can sometimes go quickly, but more often than not are gonna take a while. First, let me ask you a couple of quick questions. We saw a picture in your last slide of what the device looks like. It sort of looks like an egg beater. Tell me about its deliverability, and what's its sheath compatibility and wire compatibility, just some of the basics.
The device will go easily through a 13 French sheath, so anything greater than 13 is fine. I use the Inari Medical ClotTriever sheath or even the ProTrieve sheath to use this device, typically over an super stiff Amplatz wire. Whether you want to use the 1 cm or the longer floppy tip, it's up to you. But as long as you get enough purchase, the catheter tracks well over the wire, and what you're describing, that egg beater appearance, it almost looks like, I like to describe it as ice cream scoops. And there's 2 motions that are really involved with this catheter. One is, they call it RevCore, so it's like you're revving a motorcycle. So you're turning it in 30-degree directions to go back and forth. You can spin it around as well. And then, some people find spinning in one direction more favorable than the other, whether it's counterclockwise or clockwise, it's mostly by tactile feedback when So there is a dial-up mechanism to expand the coring element, and while the device manufacturer has provided reference guidelines on how big each tick mark or dial mark corresponds to a size in millimeters, you have to remember that a 14 millimeter stent is not always going to be opened up to a 14 millimeters. So you always want to just dial up slowly in increments of 0.5 going up, going for that tactile feedback, making sure that if you're engaging the stent, that it's still freely churning, that you're not powering through it. Because remember, you're going to get debris buildup a lot, typically on one side of the stent. Sometimes it's not always circumferential, so it's going to go to the path of least resistance. So you got to be very careful to how you're targeting it and how you are moving about. I find when I'm using, so there's the churning method or the revving method, and then there's the scrubbing method. The scrubbing method with these open cell stents, you just got to be a little bit more careful. That's why they want these stents to have been in place for at least 6 weeks, so they've kind of endothelialized well with the vessel. And then finally, I find when you're scrubbing in a wall stent, you can scrub as much as you want, and you're going to be pretty safe with that. With the other open cell stents, the Venovos, the Abres, you got to be a little bit more careful, but using that tactile feedback. The learning curve is quite not steep, I want to say, but it just takes time to work with this. Now, when you are using a sheath, let me go back to this sheath. If you're going to go from the IJ approach and send your catheter down, you want to use the Protrieve sheath above, because you're going to be collecting this debris. The debris that you're going to be liberating off these stents, I think, as Steve likes to describe, is like like Parmesan or grated cheese. So that stuff will fly up, with the flow. As long as there's good inflow, you can go inject saline, use a balloon to pull up stuff, but that stuff will come up and be caught by the Protrieve. If you're going to do what I said through a 13 French sheath, that's usually through a popliteal approach or something like that, sending up, but you got to have the funnel above to catch it too. So it is either a single access or a dual access case. I think when you're starting out, you really want to do the dual access case and have through and through wire access, so you're really working over a stiff wire here.
Great. That's incredibly descriptive. Steve, you've got a lot of experience with this device as one of the co-authors. Tell me what's the sort of typical thumbnail of these kinds of patients, and what did you do before you had RevCore as a technology?
That's one of the interesting things about this technology and the device. It's really opened our eyes to changes we can make in our follow-up care algorithms. A lot of these patients were suffering either with C3 disease, extensive venous claudication, and there were very few options for them beyond balloon venoplasty, of which we knew the patency was very low. Okay. Subsequently, you move into the categories of those patients with advancing C4 disease, C5 or C6 disease, and again, relining the stents. We've all seen them, patients who come in with 2-3 stents, left us with very few options for maintaining durable patency. So really, this device has increased that bucket of patients that we could perform primary assisted patency procedures on, as well as secondary patency procedures on. And it's changed our surveillance algorithms and how we keep those patients really following up with the office to catch these problems early on, now that we have a tool to address them as we see them.
Yeah. Hillary, tell me about in your practice. These are patients that particularly with the proliferation of treatment of nivels and other kinds of deep venous diseases, we're seeing more and more. There's a lot of discussion about the role of stenting in this patient population, but notwithstanding that, you were going to see a finite and quantifiable number of them come back with stent failures. How frequently do you encounter this in your vascular medicine practice, and what sort of a role do you think this device is going to take in your practice?
I think being in a large health network, I see a lot of venous stenting patients. The question is, do they need the stent in the first place, right? And the people placing them, do they have the expertise that the panel has? Your description of how to use the device and the ins and outs demonstrates that someone needs to have enough knowledge and experience to actually understand how to use the device and how to understand what the mechanism for why the stent failed. So I see it quite a bit, and I think this device is going to be important in terms of offering other options for patients besides just ballooning and relining with stents. And I'm excited for kind of more long-term data to figure out the patency rates that they get, and also more imaging in terms of trying to figure out the failure in terms of the mechanisms of why the stent went down, and where this device really plays a role in terms of trying to help these patients long-term.
Yeah, I mean, I think that's really important. So, Dr. Shaikh, what about imaging? I'm sure IVUS is done probably in all of these cases. Are there any sort of important gotchas that you need to watch out for? You talked about the eccentricity of these lesions. That may be an issue.
I think a lot of it comes down to uh, education on appropriate stent deployment. Do you have good inflow? Is your profunda open? Is your common femoral vein open? The GSV is more often open, but it's not enough robust flow to be keeping the stent open. I use IVUS and landing these stents in the appropriate position. You see a lot of stents deployed at outside institutions that are just not landed properly. They're caging the other side, and then you're just hoping it stays open. And so I like to use IVUS and venography simultaneously, or as I'm deploying it, simultaneous venography to make sure I'm not hitting the contralateral wall and bringing the stent back in the appropriate position. So IVUS is used in all of my cases. I use IVUS almost as a crossing tool, given the tapered end as well. Sometimes I can't get my patency to go, and my IVUS will just fly through, and I wouldn't have to open an actual crossing catheter. So that's what I tend to do. But there's a learning curve with all this stuff, and there's various programs out there to allow people to be mentors and teach people one-on-one how to do these things. So I think the education is key, and then dealing with these complications. Like Hillary mentioned, did the patient need to be stented in the first place? Can you do a trial and see if they're going to just respond with venoplasty and do okay? Why did they thrombose this point in life when they had the Mather their entire life, right? Finding out why they really did, as opposed to just doing a quick fix. And then, in terms of surveillance, yes, IVUS on all my cases. I have a follow-up imaging protocol with all my stented patients that I do primarily. I do a CT venogram at 1 month, 6 months, and then we push it out to a year. If it's stable, then we push it out to 2 years, and then we'll reassess then. I try to keep my patients on anticoagulation lifelong if I can. The antiplatelet agents are great, but they're more so for the arterial side. But if they can tolerate, antiplatelet and anticoagulant, I will leave them on that. We're now trialing one patient who's done well for 3 years now to off meds and see how she does. But, that's just an N of 1 for me.
Yeah. So Steve, as somebody who's involved in a lot of the innovation in the space, tell me about the bigger space. Where are the unmet needs, and how does this fit into that sort of matrix of devices that we need for the treatment of venous disease?
It's a fantastic device. It is a first-generation device, and some of the things that we found and learned from utilization of the device will guide us to those second-generation iterations or next-to-market iterations. One of the things that we've made reference to is the fact that this device will take the path of the greater curve of the vein or the stent, and so because it is a manual process, it can deflect off the margins of that lesser curve, leaving you with an area of residual stenosis to be addressed. So some additional directionality as well as force to gather that material that may be organized along that lesser curve would be beneficial. Also, I think we're all getting old at the same rate, and our patience and tolerance probably diminish equally. And so this is a laborious procedure. And after a few hours crossing some of these complex lesions, the thought of engaging in a 30, 45, 60-minute fluoro-intensive revving event is not the most palatable for many. And so devices that will aid in cutting down the time and maybe allow for the safe utilization without fluoroscopy for long procedure lengths would be really beneficial.
Yeah, that's incredibly, I think, prescient. I think we're all aware. I mean, again, I'm lucky in my group that I have a couple of young guys that are very, very eager to do these cases. But I've learned from years of experience that you never know what you're going to get. It's like a box of chocolates. So you can be there for a long time or not so long time, and it's always difficult to predict. And you're right, center body mass radiation, it adds up. A lot of the peripheral work we do, the amount of fluoroscopy is relatively low, but here there's usually a decent amount of radiation exposure. So Hillary, you get the last word. What if you have to put this in context? What are the biggest unmet needs in the treatment of deep venous disease, and what's on your Christmas list?
No, I think recognition, right? Appropriately diagnosing what the etiology is. I also think that we need to compare this device to other devices we have and current standard of care. So I think similar to the pulmonary embolism space, we're waiting for big randomized controlled trials to really show that the device is better than what we currently have, because these devices are expensive, right? And we want to make sure we're doing the right thing for the patient in terms of that aspect. So I think I'm excited for the current trials going on, and hopefully it's going to show that these patients are going to have less procedures and that we can really tailor the therapy in terms of both device utilization as well as anticoagulation therapy, as well as trying to prevent long-term complications in these patients and really help with venous ulcer healing. So I think that the future is bright, and I think all of us are really excited to what we're going to see.
Well, listen, I want to thank my panel and Dr. Shaikh for presenting the paper. This is an area that's relatively open territory, and it's a little bit of the Wild West as yet, and we're delighted to see that there's the rigor of randomized controlled trials being brought to bear on that space. I want to thank all of my panelists, and I want to thank you for listening, and we look forward to seeing you next time for conversations in interventional cardiology here at JSCAI. Thanks so much for being with us.